If you've ever walked out of a clinic visit thinking, I should feel relieved I got answers, but somehow I feel more lost, you're not alone. In my years of practice, I've seen the same pattern repeat across every kind of health concern, from routine screening questions to life-changing diagnoses. A test result arrives, and the number feels like it should dictate the next step, but it doesn't. Two doctors review the same information and recommend different plans. A guideline seems clear online, yet your clinician says, it depends. You try to research everything and end up more anxious and less certain. That confusion is not a personal failure. It's a predictable consequence of how medicine works in the real world. Modern healthcare is built on scientific evidence, but evidence rarely produces a single, perfect answer for a unique person with a unique body, history, and set of values. And the moments that matter most, the should I moments, often live precisely where the evidence becomes probabilistic, the trade-offs become personal, and uncertainty becomes unavoidable. This is why the best clinicians don't simply tell patients what to do. Increasingly, the most ethical and effective model is shared decision-making, a structured way for clinicians and patients to work together to choose an option that fits the person, not just the diagnosis. Today's article is about something you can control even when you can't control the diagnosis: how to think clearly and make high-quality medical decisions. This is education, not personal medical advice. The goal is to give you a practical mental framework you can use in your next appointment. Why more information often makes you feel worse, not better. People assume confusion comes from not knowing enough, so they respond by gathering more articles, more videos, more testimonials, more forums. Sometimes that helps, but often it backfires because medical decisions are not only about facts, they are also about probabilities. Risk is rarely 0% or 100%. Trade-offs, benefits come with harms. Preferences, what matters most varies by person. And uncertainty, knowledge has limits. When you add information without structure, you don't necessarily gain clarity, you gain noise. You may learn more facts, but feel less able to choose. This is one reason health systems increasingly use decision aids tools designed to help people compare options and outcomes in a structured way. Decision aids can improve knowledge and help people feel more informed and clearer about what matters to them. Clinical takeaway: don't aim to become an amateur doctor overnight. Aim to become a better decision maker. The uncomfortable truth: medicine often operates under uncertainty. Many people imagine diagnosis and treatment as a clean sequence. Symptoms, test, diagnosis, best treatment. Real life is messier. Even with modern imaging and lab work, the diagnostic process is iterative. Why two clinicians can look at the same data and disagree day. Patients often interpret disagreement as incompetence or ego. Most of the time, it's neither. Disagreement typically comes from differences in interpretation of evidence. Evidence can be high quality yet still incomplete for a specific person. Different clinicians may weigh certain studies or guidelines differently. Risk tolerance. Some clinicians are more conservative, others more intervention-oriented. Experience and specialty lens. A surgeon may naturally see surgical solutions more readily. A radiation oncologist may be more fluent in radiation trade-offs. A primary care physician may prioritize longitudinal outcomes and quality of life. Assumptions about patient values. If a clinician hasn't clearly elicited what matters most to you, they may default to what matters most to them. This is exactly why shared decision-making exists, to make the patient's values explicit and integrate them into the plan. Clinical takeaway: a good decision is not always the most aggressive option or the most popular option. It is the option that best aligns evidence and your priorities. 4. Shared decision-making. What it is and what it is not. A strong, modern definition from NICE guidance summarized in BMJ describes shared decision-making as a collaborative process where the person and health professional work together to reach a joint decision about care. Shared decision-making is not the clinician dumping responsibility on the patient. It's your choice. You decide. A patient dictating care without evidence. I want X, no matter what. Or a debate where one side wins. Shared a clinician's decision quality checklist. The 5 questions that prevent regretting. When I teach patients how to make high-quality decisions, I focus less on finding the perfect answer and more on preventing the most common causes of regret, misunderstanding, unspoken values, and unacknowledged trade-offs. Here are 5 questions that dramatically improve decision quality. Question 1. What are my options, including doing nothing for now? Many patients don't realize that watchful waiting, active surveillance, delayed treatment, or supportive management can be legitimate options in certain contexts. No immediate action can still be a decision with its own risks and benefits. This aligns with the core shared decision-making principle. Make options visible and discuss consequences. What you gain. You break the false frame that there is only one path. Question 2. What are the benefits and how likely are they? Ask for benefits in absolute terms when possible, not just relative terms. Relative risk reduction can sound dramatic. Absolute benefit often provides the clearer picture. Decision aids exist precisely because patients and clinicians can misinterpret risk without structure, and aids help clarify outcomes. What you gain. You stop being persuaded by impressive-sounding numbers that don't translate to your situation. Question 3. What are the downsides and trade-offs, including quality of life? Every meaningful health decision has trade-offs, side effects, complications, time, cost. How to have a better appointment in 10 minutes. The 3 sentences script. If you take nothing else from this article, take this. Patients who communicate clearly get better care not because the clinician is biased, but because clarity improves accuracy and collaboration. Use this script at the start of the visit. My biggest concern today is, my goal is peace of mind, fewer symptoms, avoiding side effects, long-term survival, staying active. Before I decide, I need to understand my options, the trade-offs, and what's uncertain. This instantly shifts the appointment towards shared decision-making and aligns with the collaborative model recommended by major guidance bodies. Doctor confidence can be misleading in how to interpret it safely. Patients often equate confidence with correctness. Clinicians know it's more complicated. Some clinicians communicate with high confidence because they've seen many similar cases. They believe certainty reduces patient anxiety, or time pressure pushes them toward brevity. But confidence can also mask uncertainty. Diagnostic uncertainty literature highlights how common uncertainty is, especially early in disease processes, and why communication matters. What to do? Policy safe. Practical. If you sense uncertainty, ask directly. On a scale from 1 to 10, how confident are we? What would raise or lower that confidence? Ask what evidence would change the plan. This doesn't challenge the clinician. It strengthens the partnership. When a second opinion is useful, and when it's just delaying doc, a second opinion is not a sign of distrust. It is often a rational response when the decision is high stakes, options have major trade-offs, or recommendations differ. The key is to seek a second opinion with a clear goal. I want confirmation of the diagnosis. Or, I want to understand alternative options. Or, I want help clarifying trade-offs for my priorities. Shared decision-making thrives when decisions are informed and aligned to patient values, and additional perspectives can help achieve that when used intentionally. The real reason you feel pressure to do something now. Urgency is a powerful emotion. In health decisions, urgency often comes from fear of missing a window for treatment, fear that waiting equals danger, or fear of regret. Sometimes urgency is medically appropriate. Often it is psychologically appropriate, but medically negotiable. Here's a safe way to clarify. Is this decision time-sensitive? If yes, what timeline are we working with and why? What happens if we take 2 weeks to decide? This respects the clinician's knowledge and protects you from decisions driven purely by panic. Let me leave you with this. A perfect medical decision is rare, but a high-quality decision is absolutely achievable. A good decision is one where you understand your options, you understand the trade-offs, You acknowledge uncertainty, and you choose something you can live with. If you're feeling confused right now, it doesn't mean you're failing. It means the decision matters. If this helped you think more clearly, subscribe to this channel. Here, we don't rush decisions. We don't use fear. And we don't promise certainty where none exists. We focus on clear thinking, calm understanding, and better conversations with your doctor. You can also watch the next video in this series, where we'll talk about what doctors assume you already know, but often don't explain. Before we end, an important reminder. This video is for educational purposes only. It is not medical advice, and it does not replace a conversation with your own healthcare professional. Every medical decision is personal. Always discuss your situation with a qualified clinician who knows your history.
Thanks for watching. Stay informed, stay calm, subscribe for calm, evidence-based health here on Nourish Today.